Good day, everyone. This is Taranjeet Rathore, nurse anesthesia resident from National University, and this podcast. So many people have asked me for this, and I apologize for the delay, but it is finally here. Uh, I don't feel I am an appropriate, or I don't feel I'm there yet where I can introduce Dr. MacKinnon. So, Dr. MacKinnon, Associate Director of National University, a lot of you already know him. Please tell us about
Sure,
yourself, sir.
sure. My name's Mike MacKinnon. I'm Canadian, and I trained as a medic and an RN in Canada, and then came to the U.S. To be a flight nurse. Eventually, worked as a flight nurse for a while. Worked in the ER, the ICU, did flight nursing for a better part of 7 years, and then decided I wanted to do something else. I was ready for the next step. And I looked into all kinds of things, applied to medical schools, did all the pre-meds, got accepted there. But in the process of going through that, I discovered nurse anesthesiology, and I had never heard of it before because, it's hidden, right? It's in the OR,
Right,
and I'd never
right.
gone there except for intubation clinicals, and I had no idea there was APRNs in there. I just didn't know who was in there.
Mhm.
So I once I discovered, I thought this is great, and became a CRNA. Later on, became a nurse practitioner, an FMP for pain practice, and got my doctorate at University of Alabama. Roll Tide,
Hell yeah.
and became the assistant program director at National University. And I currently sit as the Region 5 director of the American Association of Nurse Anesthesiology. And I've been past president and on the board here in Arizona a number of times. So that's a little synopsis about my history in anesthesia.
We could dedicate this whole podcast on Dr. McKinnon's endeavors, but without wasting any further time, let's dive right into what we're all here to listen. So, first question first, sir. National University is very famous and it's known, and more so over the last couple of years, for cultivating independent practice ready CRNAs more so. So, what core philosophy drives that focus?
You know, uh, Originally it came from my experience. When I was looking for a school, I had no idea that where you went would determine the clinical capability or exposure you may get to independent practice. I just assumed all schools were the same, right? Like, why would you think
Right,
otherwise? And keep in mind, when I went to school, there was no Facebook or anything else. So it wasn't an option to just quickly get that information and talk to people about different programs. You just assumed that that was the case. And
right.
so when I was training, my program was fine, the didactic part, but in the OR, I found I was very restricted and, wasn't allowed to push my own induction drugs, wasn't allowed to do any kind of blocks. I was limited because I was being restricted by another group of practitioners. And that was really frustrating to me. And so I knew that when I graduated, I was not going to work in that kind of a model, a traditional anesthesia care team model, because as a flight nurse, I was able to do more independent practice than the CRNAs were in many cases where I was training. I put in
Wow.
chest tubes, I intubated upside down in cars, I'd done central lines, I induced myself, paged my own patients, I did pericardial centesis, I criked patients, all without anyone else there but me and a paramedic partner. And I was also a medic. And so I knew that I wasn't interested in a practice that was less than what I'd come from. So I went right to an autonomous style practice when I graduated. And I vowed that if I could go back and do anything, I was going to change that for the profession. So the first thing that one of my best friends, Scott Rigdon, and I did was create CE2, where we, for many, many years, trained CRNAs how to do ultrasound guided regional anesthesia. And by the time I was done, I was doing blocks that they hadn't heard of where I had trained at. And so I was teaching CRNAs and giving them the opportunity to do these things that I didn't get the opportunity to do in my training program. And there were many other CRNAs that didn't. Now, today, I think ultrasound guided blocks are relatively common in most programs, at least taught. You may not get a lot of exposure in some programs. And I knew I wanted to be part of something that was big. So I started there. From there, National University, I got my doctorate, and a friend of mine had started the program. His name is Dr. Brian Toon, great guy, very good friend of mine. And Dr. Joe Martin is the assistant program director at the time. They hired me to be faculty to create a lot of the doctorate courses. And then eventually I became assistant program director, and Joe Martin became the program director. And our goal was to develop a program that focused on the motto that we now use today, which is we train clinicians, not technicians. And so we focus on entirely upon an independent practice, autonomous practice mindset. So you graduate, you're capable, and you've got the critical thinking and the mindset to go practice on your own, or in an autonomous model, or in a collaborative model, or in an anesthesia care team model, but you'll always have gotten the training to branch out and be independent. And that was our primary goal, because so many people were in this situation where they graduated and they wanted to go work independent practice, but they never got the experience. And how are they ever going to get it? Because no one would hire them because they didn't have the experience.
Right.
You see what I mean? It became a vicious
Yeah.
cycle. And I didn't want people to have to fall into that. So we redesigned this program to be about independent practice.
No, I love to hear it. That was also one of my reasons why I chose national, and it was one of my top choices. I mean, it was one of the top paragraphs in my personal statement too. You mentioned about Scott. Shout out to Scott. He's one of my mentors. I got in connection with Scott through AANA, so love the connections here. So beyond the usual, for example, science GPA and the ICU hours, numbers of training, years, what qualities signal to you that an applicant will thrive in such a clinical autonomous program?
You know, it is a puzzle when you're going through the interview and application process. So at National, we'll get anywhere between 450 and 550 applications for 30 spots. Of those 450, 550, probably a good 80% of them meet the minimum qualifications. But I mean, as you know, and as anyone else knows, the minimum bar, the low bar is not enough most of the time. And so
Yeah.
we're looking for people who bring something different and want to really focus on being independent practice. So what are the things that we look at? So I developed a rubric where I grade people based upon their application and interview, and that's what we use. So some of the things that we want to see people who want to be independent. You know, so they've read Watchful Care or Watchful Care 2, either of those books. They've gone and shadowed an autonomous or independent practice CRNA to see what the difference is between that and an anesthesia care team. Maybe see both, right? And they've put the work in to understanding the nature and the trials of the profession over time. And so we like to see people who do that. I put all this in our frequently asked questions stuff. And we want to see people who become affiliate members as RNs of the ANA, because ultimately the ANA is the only organization that's there for CRNAs, and that should be your primary resource for information. So just 2 years ago, we developed that as a primary resource, and it rolled out this year, and we've got 1,100 members already, RN
Yeah.
affiliate members, and it's growing rapidly. Why? Because just go to the source, you'll get the best information. There's lots of third-party companies out there. They don't do a poor job, but they're not the ANA. And then I want to see people who have a good personality, right? Because anesthesia exists in three simple things, the three A's: affable, you're nice, you're fun, you're easy to get along with; available, you show up, you're there late, you come early; and able, you're able to do the work, manage the workload volume, and be successful, right? Because anesthesia school is not like other programs. It is drinking water from a fire hose. It's often what's said. And more importantly, you have to get a B just to pass, right? So just to pass is a B. Anything less than that is failing, and then you're out. So we don't want to set people up for failure. We want people to come in. Sure, GPA is great, but science GPA is what matters the most. Taking maybe some advanced pathophysiology, anatomy, pharmacology classes, graduate level, helps us see that you can do the rigor of graduate level classes. That's helpful. Not required, but it's an additional thing someone can do if they want to stand out. Being an affiliate member, that helps you stand out. And then we ask a lot of clinical questions that are very focused on where someone says they worked. And so we want to see if they know more than just, sucks as a depolarizer. We want to know if they know why it works and how it works. So if you say you work in a respiratory ICU and you've got all kinds of vents on all kinds of different settings, but you can't explain any of them, I know most of the time RTs take care of this, but that doesn't stop someone from learning about it from the RTs, right?
Absolutely.
So So we want people that are willing to get in there and want to learn, self-starters, because graduate education is not for the weak of heart. I'm not spoon feeding anybody, and I'm not interested in doing that. So adult learners have to take accountability for their own work and put their own time in. And part of it is self-learning, and that's just the nature of all graduate programs and PhD programs. And ours is no different, but the volume is higher than many other programs. Having done two, a nurse practitioner program, having done a doctorate program, and my own master's CRNA program when I went through, those compared to the CRNA program. So it's something I think we're looking for people who really can do volume and rigor in time-dated periods of time, right? There's quarters, there's 12 weeks, or there's semesters, there's 16 weeks. And there's a lot to do and get done in that time. So it is a lot.
It is a lot. It is a lot. You kind of spoke about, you kind of already talked about my next question, but you didn't mention there is clinical questions which are tapered. So anything that you put out on your resume, your CV or application is fair game. And I would like to highlight the point that I was just speaking to Dr. Kramer. He's one of our faculty, awesome person, awesome professor, and currently we're at 450 applications in progress, and it doesn't close until July 31st. So there's still people who are getting on it, but yeah, it is pretty competitive. So thank you for answering those questions. This is actually a question from one of the applicants. I'm going to ask you word to word, but they asked, how early in the curriculum can you expect students or residents begin taking primary responsibility for case management, and how is the supervision tapered?
Good question. So I'm going to focus specifically on our program, but before I
Right.
do that, I'll talk about the general. There are two different types of anesthesia programs out there that you can get accepted to. There are front-loaded programs where you do didactic all the way through. In our programs, that's 15 months, and then it stops doing the anesthesia didactic. So you've done all the anesthesia-related coursework, and then you go to clinical residency, and in that time you do the doctorate courses, which are far less intense comparatively. Things like the business of anesthesia, learning about how to communicate within teams, all that kind of stuff. Much easier to do when you're also in clinical. You'd never survive doing both at the same time, in my opinion. The other option is integrated programs. And those are programs where the first 2 or 3 months, you probably just do didactic. And then you do 1 day a week of clinical and 4 days a week of didactic. And then eventually it's 2 and 3 and 4. And it's all the way down until it's 1 day a week of didactic and the rest clinical. Now, many people will have come from the education model of see one, do one, teach one. That's how I was trained. But I think that the model of integrated is very difficult to manage for many people. Not that it's bad, but it's hard because tomorrow you could have a case on your schedule and when you're only doing clinical 2 days a week that you haven't even covered in your anesthesia program yet. And now, obviously, those people in those clinical places know that you don't cover everything and then just show up with it all ready to go because they're dealing with the same residents. But the truth is, you're going to feel under the gun and not have answers. And that's a little harder than when you do all the didactic, which is hard because you're not actually seeing it in process until you actually get in the OR. So it makes it difficult. That's the downside to front loaded, right? It doesn't become real till you're in the OR for the first time. But the front-loaded programs do you a bit of a service, I think, because even though you may not remember all of the details, all you now have to do is review. You don't, and it might recall just from having questions. You don't have to go and try and learn how to do a kidney transplant and all the information because you haven't covered it yet, right? The downside to front-loaded programs like ours at National is you did a machine check like literally in the first couple of months of your program, and now a year and a bit later, you're being asked to do one in front of someone. So you do have to review.
What is Samtide? What is Samtide?
Yeah, all those things. You're trying to remember that stuff, right? So in our program, we do 15 months of didactic. It's very intense. When people wash out, they generally wash out in the first 2 to 3 quarters of the program. Sometimes at the end, but of that 15 months, but mostly then. And then from there on in, the next 21 months is all clinical time, right? And our nurse anesthesia residents do a lot of clinical time. And it is designed that way. And if people want to go somewhere where it's easy and they don't want to work too hard, and they want Monday to Friday, 7 to 3, and get out at 3 o'clock and go home early, or they want it to be like nursing school, don't choose National, right? You won't graduate as capable, but at least you won't have to worry about working very hard. That's not the goal, right? The goal is to graduate being the best you can be and capable of going to work anywhere. That's the goal. That's why our graduates are so highly demanded in the employment realm. And we get asked all the time for people to hire them, even before the shortage. So the reality is, in that 21 months, on average, our residents will do about 4,700 hours worth of clinical time. Now, that's time counted from the time you go to the hospital to the time you go home, not a case start stop time. So we're counting it the same way the physicians do, right? So right around 47 to 5,000 hours in a period of 21 months. So it's a significant commitment. Sometimes there's 24-hour call, sometimes there's weekend call, sometimes there's days that are 16 hours, sometimes there's days that are 6 hours. But for the most part, on average, it's around 50 to 55 hours a week over the period of that 21-month time frame. So you're right in the 5,000 hour range all day.
I can definitely vouch to that. Last week I was at 58 hours, right around there. So
Yep.
you're pretty accurate about that. We do get a lot of numbers cases, and numbers is not an issue for National University. Right on. So moving on the same point, a tangent perhaps. What kind of clinical sites or rotations Nationals provides, which fosters the solo ready-to-go training model? Can you talk about clinical sites a little bit?
Sure. So our program, because we focus on autonomous and independent practice, what we really want to do is send people to sites that have those practices, right? It's very difficult. I think Edelman said it best in her quote, "You can't be what you can't see." And that applies both to people that look like you being something, but it also applies to practice models. If you've only ever
Absolutely.
seen a restrictive anesthesia care team, how will you ever know if you want to be in an independent practice, or what the difference is, or what that looks like? That's not to say care teams are bad. They aren't. Everyone makes the choice of where they want to work, but we focus on getting people in autonomous rotation. So anywhere between 70 and 80% of rotations will be at either autonomous or independent practice clinical sites, including my facilities. So, we have nurse anesthesia residents come here. You're going to be coming here probably for about 6 months. And so, we'll beat you to death. And while you're here, you'll follow a CRNA schedule, right?
Right.
Except you won't get the time off they get off,
Right.
but you'll follow their schedule. That means 24-hour call. That means weekend call. That means post-call day off. That means, 8-hour days, 10-hour days, not shift work. And so the benefit is you'll also be able to block just about anything and take care of just about anything when you leave here. And a testament to that is all the residents that graduate from our program go straight into independent practice and do amazing. And I know that because I hear back from the people that hire them, because they know me. So I get the 411 on how they're doing when they graduate. And the vast majority of our graduates are capable of hitting the ground running independent right out the gate. And
Right
that's
out the
our
gate.
focus.
Very well, and thank you for the early notification. I cannot wait. I cannot wait. I already have my shoulder gear ready. But so can you talk a little bit about, because a pivotal piece of our curriculum, which is not often highlighted in my opinion, is the 12 months of simulation, the high fidelity simulation we get at National University. And I feel like a lot of applicants do not know about that. And another thing that our program also does is mission trips and the focus on POCUS with Dr. Kramer. Can you talk a little bit about that, sir?
Sure. Let's start with POCUS, right?
Right.
So Kramer and I are very dedicated to ultrasound related work. And the reason why is because ultrasound is the new stethoscope. Handheld ultrasound like the Butterfly IQ or the GEV scan or any number of devices out there now or that are coming, add a piece of information to your decision tree that could be critical. And so we both dedicated ourselves to developing point of care ultrasound. Dr. Kramer leads this. And we start that ultrasound training in the very first quarter. Everyone in Nationals program gets a Butterfly IQ or 3 or whatever the next iteration of it is. And they're assigned assignments to scan abdomens and scan their kids and scan home. And the great thing about that, as opposed to a program that only has an ultrasound in a lab, is that you take it home with you. It's yours. And so you can scan your husband, your wife, your friends, your kids, your dog, whatever. And it allows you to get practice with a device scanning and finding out what is the easiest way to see it and how to make that canter or tilt or heel toe work to get an image, right? What does that do? It does a lot of things. First of all, it gets you very comfortable with handling an ultrasound and understanding depth, understanding, the density or the difference between echogenic structures and non-echogenic structures, hyper echogenic and open structures like vessels that are black in the middle. Those kind of echogenic signals, learning that, but also just how to hold the ultrasound in your hand, how to put it on somebody, how it's very different from a mannequin, right? Because people aren't all exactly the same. Some are big,
They're
some are
not.
small, some have massive muscles, some have tiny muscles, some have a lot of adipose, some don't, you know? And so all those things you learn. And as you're learning that progress, you learn how to do fast scan, gastric scan, airway scan, lung scan, TTEs. When it comes to learning to do blocks, now all you're doing is learning how to put the needle in the right place because you've already learned how to identify the structures, manage the ultrasound, and blocks come much easier, right? So POCUS, we integrated right at the beginning of the program. And just this last year, we got the intelligent ultrasound, which is a full mannequin where you can do TEEs. And we have a cardiac physician anesthesiologist friend of ours that are going to come and teach all of that for us because he does it every day. And then you can do TTEs. And you can do every kind of POCUS scan from about mid-thigh all the way up to the airway, everything. And it has actual images on the screen of real anatomy in real time while you're scanning this mannequin. It's amazing. And then on top of that, we have the block trainer that comes from Intelligent Ultrasound, where you can use a GEV scan that comes with it. You got a picture up there of a real person. I put it on you, and I got a needle that retracts into the back and shows the needle going toward the structure. So you can get a sense of how to do an ultrasound block on a real person in your cohort, not just a mannequin that never moves, right? So that's POCUS. And in that process, we want to make sure people were very competent because, blocks are high risk things. When you've got a lot of high risk real estate right here in the brachial plexus, high risk, and in the back of the leg with the common peroneal nerve specifically, you could cause a lot of damage. So we want our residents to graduate as prepared as possible and to enter clinical residency as prepared as possible so that they're safe. Right? Identify what not to stick with the needle, identify where the no-go zones are. Those are the key things that we start teaching. And then identify where to put the needle and learn how to make the management and movements that are millimeters sometimes to make the visual the best. An ultrasound is just a credit card width, right?
It
So
is.
when you learn to do it on a real person, it's much better. So that's the first thing we started with. Within the lab itself, on top of that, we've got a dedicated lab, and many programs share their lab with multiple other types of schools in their university, right? We don't. We have our own dedicated lab. And so our nurse anesthesia residents have the benefit of being able to go in there Monday to Saturday, basically all day into the evening, and practice in groups with each other. And then we have two lab instructors, Dr. Leese and a new lab instructor that just started that will pick up on the next cohort. And those two will have small groups of nurse anesthesia residents that they're training how to do all of the things that we do in the OR. And then, of course, we have lab exams and final exams and all that good stuff that people are terrified of. But we have all the basic equipment for people to learn on, and I think it's pretty fun. And our lab is relatively well equipped.
Absolutely. Thanks for mentioning that. I'm also a little bit jealous of the cohort 7. That new
Yeah, I
machine that
know.
they got is.
Yeah.
I
Oh,
was looking at it, playing with it a little bit.
it's
But yeah,
cool.
go ahead.
And
It's
you
pretty
wanted to know
cool.
about mission trips. So,
Yes,
um,
mission
Doc,
trips.
Dr. Kramer is very well known for his international mission trips, including to Mexico, living there for 5 years, doing anesthesia and critical care. He's an MP, same as me, along with being a CRNA. He's also very well known for going to Iraq, Iran during the war there. He's been in in Africa doing Ebola clinics. So, he has clearly no fear. And so
That man fears
he,
nothing.
yeah, he wanted to bring in mission trips, and I got to go on a mission trip when I was training with Healing the Children, which is like Operation Smile kind of thing, to Colombia. And so it was a transformative experience for me, very humbling. And so I thought that'd be a great idea. So we started with a number of different types of mission trips, and now we are the only program in the country, and we still are, that has a 3-month rotation to an actual mission trip hospital that's part of the continental US. The benefit of that is that you can count your cases there toward your COA requirements. And so that has been really an amazing thing for us to be able to do that. We've had now 3 or 4 residents, I think, gone, and they just had
Yeah,
a phenomenal experience. It's basically a CRNA driven practice. So
it
it
is.
has
It
been
is.
amazing.
It is. No, I'm speechless, to be honest, because we're the only program who you also get the benefit of the mission trip, but you're not in that state where you're feeling, oh, I'm not getting these numbers, right? So it feels like you're hitting two birds with one stone. So I know this personally through our didactic. I am every resident is paired with a senior resident in terms of mentorship, but I would like for you to express, because I do know that you did mention that no one is spoon fed, which is true, and it is like drinking water from a fire hose, but there is mentorship available. Can you talk about, because independent practice and just the school and just CRNA school in general can be very intimidating, but so can you talk
Sure.
about the mentorship that we offer? It's not just
Yeah, we're not just throwing people to the wolves.
yeah,
So
exactly.
the benefit is every person who teaches has been where you all are, or where the people watching this are going to be, right?
Right.
They've been in the application phase, they've been in the beginning phase, and it hasn't changed that much from then till now. The technology's changed, maybe some of the information, maybe some of the resources and the clinical site rotations, but the truth is the feelings are all the same, right? So we're all also, everyone who teaches for National University's DNAP program are independent practice CRNAs. So not only do we know where you are now, but we know where you're about to head to, or what you're in when you're in clinical residency. And we know that it's independent and it's very different from other options. So as a faculty, we are super supportive and very available, right? So anytime someone needs to talk, and it probably happens once a week, or needs to have a conversation, I hear from a nurse anesthesia resident, they have direct access to all the faculty on the app that we all use, and obviously email and text message and everything else. And so there's that part of the mentorship, right? The second half of the mentorship is that truly in your life, right? Whether you're married or you're single, or you have a girlfriend or a boyfriend or whatever, no one will understand what you're going through that hasn't done it, right? And even though we've been through it, we are distant from that time, varying degrees of distant from that time. So understanding what it is now, or how it is for you now, is generational in some degree. So no one ever gets it except for people who are in it, or recently in it, like you, right? Or the people who have come just slightly before you. So we sat
Right.
down and tried to figure out what was the best way to do this. So we developed a mentor program where senior residents would be led by their basically chief NAR, nurse anesthesia resident, the class rep, if you will, uh, and they have a separate, away from us, faculty are not invited or involved, meeting with the incoming cohort to tell them all the things, right? To talk about what it's like, to talk about how horrible this is, or how great this is, or these challenges, or how this was rough, or this clinical site was hard, or this preceptor was rough. And as they're meeting as a group, people gravitate to each other. So instead of me just assigning Taranji to Bob, and you guys have absolutely nothing in common, turns out you don't like each other. And that's what happens in some other programs, right? We let the residents decide to pick the people who they connect with the most, right? And you quickly figure that
Absolutely.
out. And so, and if that was needed to change, it could change. There's nothing, it's totally outside of our control, and it's that way by design, so that the you get an attachment with someone who was just recently where you were, but also knows where you're headed and can help prepare you. And many of these people, not everyone, because you don't connect with everyone no matter what. Many of these people stay connected after graduation for
Absolutely.
years. So I think that helps develop that attachment and support system that's the very most genuine, right? When people are equidistant from graduation as you almost by a year, they really know what you're going through and the trials and tribulations, and they can help with that. And so I think that's far better mentorship than having a CRNA mentor, because they're just working. Like
Yeah.
their perspective is very different. Your
There
life
is.
is complicated. The wife, the husband, the girlfriend, the boyfriend, the kids, the family who don't understand why you can't come to the birthday on Thursday at noon. Like those kind of things are very different, right?
I'm missing my younger brother's graduation, but
There
it's
it is.
it's part of the game. It's part of the
Sacrifice.
game. It's sacrifice.
Yeah.
It's sacrifice. Dr. MacKinnon, what's one misconception that you hear about independent practice heavy programs all the time, and you wish that the applicants would drop that?
So I think there's a couple. The
Yeah,
first most
please.
primary one is that independent practice CRNAs do bread and butter cases that are very easy. Maybe they do cataracts or maybe some colonoscopies or, maybe a very healthy patient with a lap chole or lap appy. And that's just not true. So in our practice, we do triple A's, both open and endovascular, EVARs, endovascular triple A's. We do VATS cases, video assisted thoracoscopies, and VATS open cases, and then we do kids, we do adults, we do sick adults. Anyone who comes to the door in a trauma situation, we take care of that. So there's no. I'm sure there's places you can go where you can do bread and butter cases, but I've not seen those personally. And the vast majority of CRNAs I know don't work in those places that work independently. They work in more rural areas where patients are just as sick as they are in the urban areas, if not more so, because they have less necessary access. And I think that that's one of the primary misconceptions about what independent practice means. We're not doing physical status 1 and 2 cases all day long. In fact, the vast majority of my cases are threes and
Four,
yeah,
three, and
and
four.
that's
Yeah,
just the way it is, right? We're responding to the ICU to put in the central lines and intubate patients because there's no one else to do it. We're responding to OB for the emergency C-section. We do 800 to 1,000 deliveries a year at our community hospital facility, right? Those patients aren't all healthy. They have preeclampsia. They have eclampsia. There's emergency sections that happen. CRNAs do that independently here, and they do across the country. And I think that's one of the primary misconceptions. I think the other misconception is that CRNAs who are working independently are cowboys and cowgirls, right? They're just out there knocking patients off, taking risks. And that is not the case. Anyone who's ever worked independently at anything in their life realizes that it's much more easier to be nonchalant and cowboyish when you have a backup. When you are on your own and it's all on you, it's a very different perspective for everything. And so the truth is those people become the safest possible practitioners because there isn't somebody to come in at 2 in the morning to help you out
there
with
is
that
no plan B.
major
There
trauma.
is there's
You
no
know,
plan B.
there's no
Yeah,
plan B outside of you, right?
yeah,
So that's
exactly.
the nature. And that doesn't mean we don't help each other and come in when we're not working to help each other with bad, hard cases or whatever. But what it does mean is that you have to be capable of doing it all on your own. So when I see like 2 people doing a case, I'm baffled by how that operates because I just do it myself and the outcomes are the same. So that's probably the bottom line.
I think you covered it pretty nicely. So if I were to go back, and I already know the answer to this question, but if I am a ICU nurse right now, and I'm an applicant and I'm listening to this podcast, what specific habits or experiences you think I can cultivate currently to even think, act independently, and apply for National University?
It's a common misperception that nurses are just order takers who show up, do what's said on a sheet of paper on a computer screen, and then sit there waiting for something to change and then call someone and do what's said again. That is not how it operates in critical care areas. It just isn't that way, and it could never be that way. So we're not, it's not your like an office nurse who's drawing labs. It's not that way. And so my expectation for RNs that are interested is to be autonomous. Within your scope, be as autonomous as possible. Never settle for surface level knowledge, right? You want to understand why you're doing what you're doing, why the drug works the way it does, why a patient with this particular disease process needs this particular treatment versus another one, right? Because protocol followers are not what we're looking for. So the people that we want are the people who are investigative A types by nature. They want to know why they're doing the thing. So, if you're in the ICU and there's a physician in there, a critical care fellow, and they want to order this, talk to them about it. They'll be more than excited. Physicians are some of our best advocates. They're more than excited to teach you about what they're doing a fellowship in because it's exciting to them. And someone who wants to know it, they're like, they're excited to do it. Or the nurse practitioners or the physician associates that are in the ICU that have been doing it for a while. Talk to them, ask them why. Why not this versus that? You'll meet people that you connect with that will teach you amazing things. And that's what we want. We want people who are invested in their own knowledge base, right? So it's not enough to know the surface level. Scratching the surface has never made someone a great CRNA. Because when you get to anesthesia school, you'll learn a lot of what you didn't know about what you thought you knew a lot about, right? Because though anesthesia is a narrow specialty compared to, say, family practice, it is extraordinarily deep in comparison. So the expectation is very high on understanding why, and that's a large part of the process. And I think that's probably what I would say is the most important thing.
You get humbled very quickly. You get
Yes, you
humbled
do.
very, you get humbled very quickly. So, as we're ending this podcast, just last couple of questions. What are some common pitfalls or mistakes that you personally see? Because you have sat in like thousands of interviews, but that you see in personal statements or interviews
Yeah, that's a
for
great
applicants?
question.
Yeah.
There's a few. So I think that, when you're writing a personal statement or an application or an introductory paragraph, you should talk about why it is that you want to go to the program that you're applying to. A generic personal statement, I don't even waste my time reading. We've gotten personal statements that said other universities' names in it. And that's why X university is my first choice. And we're not that university. So, I mean, that to me speaks to vigilance, right? Attention to detail and dedication. Because if you're only willing to give out a bunch of generic stuff or you make mistakes like putting another school in there, and yeah, everyone makes mistakes, this is not the time to do it. I'm going to judge you on it. So, this is an application. You're being judged on your application. If you didn't double and triple check it, what does that mean for you in the lab, right? What does that mean for you in the OR? Because
In the
there's no
OR.
room not to double or triple check it, right? Another thing is being willing to say, I don't know, right? The safest providers that exist are the ones that recognize that they don't know everything. And the longer you're in this career, you start off, you graduate school knowing the very most of everything, right? At that point. And the reason why is because you just finished all the didactic, you just passed board, you're the smartest you'll ever be as far as data and facts. And you think, yeah, I'm killing it. And then the first 6 months you're doing okay. And then you're starting to realize, wow, there's a lot that I'm still learning. And then it's a slow process of, man, there's so much I don't know that I'm learning as I'm practicing. And that's why it's called the practice of anesthesia,
Yes.
not the expert of anesthesia. We're all experts, but we're expert in practicing and learning and engaging. And so in the interview, when a question's asked that you don't know, you should say, you know what? I'm not 100% sure, but let me try to reason through it and I'll do my best. And if not, I'll get back to you with the answer after the interview. I appreciate that as much as the right answer, right? Because being able to humble yourself and say, you know what? I don't know, and is a level of maturity that really does matter, right? And I think one of the other things that we see a lot is people come to us with struggling GPAs over a history, low GPAs over a history, and we make it very clear that I don't know the people that are applying, right? So I'm going to judge them against other people who are applying based upon three real things: their experience, their academic acumen, and their interview. right? Those are the three things. And so, and then all the other side notes that add points to their system, like you're an affiliate of the ANA, you did diversity CRNA, you know, all those things. You've got recommendations from someone that the program knows that's trustable. Those things all matter too, but the three biggest things are the three I mentioned. And so we get people who think that you know, well, I'll say, well, why didn't you retake that chemistry course you got a C plus or a B in? Well, because I just know I can do it. I know I can do it. Like everyone thinks that they know they can do it, right? But nobody knows what it's going to be until they're in it, right? And so you can be the greatest interviewer, you can be the greatest believer in yourself, but I don't know you. And so I have to judge you off these things. And what I hear when someone says, I didn't bother to retake that course, is you were looking to not do the work. That's what I hear. And so if you're not willing to do the work to retake a course that you got a poor grade in, that's a science course that's going to matter to us, then are you going to be willing to do the 100x amount of work when the time comes that you're in the program? It doesn't sound like that, right? So one of the biggest mistakes we see made is people think, well, I just didn't want to spend the money and the time, the X, the Y, all the excuses, right? But the bottom line is you have to look at the perspective of the program when you're applying, right? The lens of us is we are judged by our accreditors on only two things: attrition rate and NCE pass rate, and that's it. Everything else can be horrible in the middle. It's silly that this is how it is, but this is how it is because it's the only way for the accreditor to judge en masse. And so we want to accept people both that we believe in, right? That we think can do it, so that we're invested in them, but also that have what appears to be, at least on the surface level of the application, interview, and experiential level, will be successful at not being kicked out of the program or quitting, right? And passing the NCE, the boards, and the C exams in the middle. So the only way for us to measure that is how well they do on science courses for the most part when it comes to just sheer volume of work and rigor and difficulty. And so if someone's not even willing to retake a course and they just think that they can take a flyer and make it happen, I mean, yes, there's also people who smoke full time and don't get lung cancer, but that's a unicorn, just like the person who gets admitted with 1 year of experience or gets admitted with a 3.0 GPA or, you know, gets admitted that bombed the interview. Those are all extraordinarily rare. And so, and it may be that they did phenomenal in the other pieces, or it may be that the program was desperate. It just depends on the program. I'm not desperate. So, you know, for us, it's going to be picking the best of the best. And while some people will feel that that's unfair, right? Well, everyone got a 3.9 GPA, but that's not the only thing we're looking at. It's the sum total of the application. And so the 3.9 GPA is great because it suggests to me that you can do hard courses. There's lots of other pieces of that, variables like how rigorous the place you went to get the 3.9 GPA is, but I can't know every place, right? So I'm going to take it at face value that you do the work. But if you bomb the interview and can't answer a simple clinical question where you work, that 3.9 GPA doesn't mean anything to me. You see what I'm saying? But the
Yeah.
guy who got a guy or girl who got a 3.5 GPA that nails the clinical question in depth, because, you know, when they were in university, they went out drinking a few times and got a B in a course. That individual, now that could make up the difference. You see? So it is a sum total, but all of the pieces are important.
It's a holistic approach. If you look at the whole
Yep.
picture, it's just not one factor.
Yep.
All factors are equally graded. So, last question: where do you think National University is headed in these next 5 to 10 years?
So I think we're going to do more of what we've done, which is be on the cutting edge of technology, advancing ultrasound and the profession, being the people who graduate CRNAs with the most amount of block experience and ultrasound experience and independent experience and critical thinking experience. and adding faculty that fall in line with that expectation and future planning, right? So I know we're going to expand the cohort to 35 at some point in the next couple of years, but we're not going to do things before we have the ability to do them faculty-wise, resource-wise. The university is very happy with our outcomes, so we're happy with our outcomes from our graduates, but certainly the goal is to grow, right? Grow our brand, both as National University, where we train clinicians and not technicians, and there are places you could go where you'll graduate as an assistant. And so we don't want to be that ever. And so the people in the program, the people who are accepted to the program, and the people who run the program and teach in the program, we should all be swimming in that same direction. And that means adopting technology that happens, doing things that other programs aren't doing. The business of anesthesia course that we teach, that I do, the way we do our communication courses, the doctorate courses are very different from most programs, and they're made that way to be anesthesia, centric. And so I think we'll do more of disruptive innovation. And because when I was complaining about programs when I graduated and said why don't we have required independent practice rotations? Why aren't we doing more blocks? Why aren't we this? Why is the numbers for blocks so low? Why are the numbers for epidurals so low? All the things I complained about, I was pushed back by long-term educators saying, well, that would close programs. You can't you don't understand because you're not a program director or assistant program director. So when I finally got to the point where I made it happen. And the truth is, if there's a will, there's a way. And
Absolutely.
I did the things they said couldn't be done in this program. Dr. Martin, myself, and the faculty as a group did that. Obviously nothing was done by me. It was done by us. And we made that happen as a group because it was important to us. All the things they said couldn't happen, all happened. And so I think we're going to see more of that.
Hearing about all of this, someone who's been watching this podcast for the last 45 minutes, someone who is maybe intimidated, even scared, they might have the grades, they might have the experience, but they might get a little bit intimidated in terms of what's out there, in terms of CRNA school, independent practice sites, and just how hard it is. What's one piece of advice for them which you can tell them to just go ahead and apply?
This is the best profession and job I've ever had. It is a slog to get through it, but when you're done, it is so worth it. And a large part of being successful, and you should just apply. When you've gotten to the point where you're ready, apply, right? Even if you only have 2 years of experience, we accept lots of people with 2 years of experience. I think the sweet spot is somewhere between 2 and 3, 4 years of experience. Young enough to have neuroplasticity, experienced enough to have experiential education in that process. And the basis for all that really comes down to what I constantly preach, which is the 6 Ps. Proper planning prevents piss poor performance, right? So if you've planned, if you've gone through the process and you've been deliberate in preparing yourself, you'll do great in this program. It sounds intimidating, but people do great when they apply themselves and they dedicate themselves. And that should be your life for that 3 years. It doesn't mean you don't have another life. But when I see people say things about, well, I want to have a work-school balance, a life-school balance, I don't know what they're talking about because it doesn't exist in an anesthesia program. That doesn't mean you can't go out and play basketball with your friends or go out and do pickleball or hang around with your kids and your wife and go to important events. That doesn't mean that doesn't happen. But there's no balance. It's all one-sided. It's the program.
Sacrifice.
It's
Yeah,
sacrifice, right?
exactly.
If it was easy, everyone would do
You
it.
won't be
So if you're
doing it.
looking
Yeah,
for some sort of weird life school balance, you're not going to find it in anesthesia at any school. I don't care what they say because it just doesn't exist, right? So the plan is to be dedicated and you will be successful.
it's funny how you mentioned the 6 Ps. One of the CRNA who was my preceptor today, he's a national graduate. I'm pretty sure you know him. I'm not going to say any names. But he was just talking about that today. The 6 Ps that MacKinnon talks about. And I was like, yes. I was like, yes. All right. So before we end this, some rapid fire questions, okay?
Yep.
One word that captures National University CRNA school.
Innovative, disruptive.
Disruptive. I like that one. So favorite solo victory story from a recent graduate.
Probably
Something.
David Warren. So David Warren just graduated in cohort 4, and now he's out doing independent practice locums, and he is very thankful for the education he got with National University because he feels far more prepared than some people that he even works with.
He's in Alaska. I love that guy.
Mhm.
A regional block that you cannot live without.
Brachial plexus block or interscalene block because we do a
Interscaling
lot
block.
of shoulder, arm, wrist surgery is pretty common. There are others that are equal related to legs and stuff, but that's the one I think about the most.
Coffee, meditation, or both before a tough shift. I don't know
I
if
don't
you're
drink coffee, but I do drink 5 Hour Energy. Coffee tastes like dirt water to me, but it smells great. So for me, I would say before a long shift, I always caffeinate,
right.
and to get me at peak performance.
Last question. If you could travel back to your days in nurse anesthesia school and you could give yourself a single advice, what would that be?
Uh, Pick a program where independent practice is the focus.
Right on. So this is it, guys. This is the podcast that you all have been requesting. This will be available on Spotify and on the YouTube channel Sikh Anesthesia Podcast. Please join me in thanking Dr. MacKinnon for being a guest on this. I know you're a very busy guy.
Yeah, it was great to do it, Taranjeet. I'm glad we could make it happen.
Yes, sir.